So I was asked to talk about recurrent urinary tract infections with particular reference to contemporary management and future options. Urinary tract infections are a very common complaint presenting to urologists and urogynecologists alike. They account for over 150 million physician visits in the US per year alone. As well as community infections, hospital-acquired urinary tract infections are very common, and these can often be with the most resistant bacteria. In England, it's estimated that about 1 in 6 hospital-acquired infections are secondary to a urinary tract infection. Urinary tract infections are usually defined as 2 episodes in 6 months or 3 in a year. Recurrent urinary tract infections mostly affect younger sexually active women or postmenopausal women. The difficulty with treatment of recurrent urinary tract infections involves the rise of antimicrobial resistance that we're seeing currently. If you look at the levels of resistance, particularly described by the Global Prevalence of Infection and Urology study, they're quite alarming. Regular daily antibiotics are the gold standard for management of recurrent urinary tract infections, but as antimicrobial resistance increases, we need to explore non-antibiotic options. There are good quality meta-analysis available concerning the use of cranberry products, systemic and topical vaginal estrogen, and the urinary antiseptic methenamine hippurate. I'm currently leading a large trial in the United Kingdom to evaluate the use of methenamine hippurate with the comparator of daily antibiotics. There is a degree of evidence base also to support the use of vaccines, and in general the oral vaccine has been shown to be the most successful in terms of UTI prevention. Intravesical treatments, which aim to replenish the ganglia, have also been shown to have some success in the treatment of recurrent UTIs. Future prospects would involve the development of newer vaccines or perhaps some kind of modulation of our own immune system. There is some interesting data emerging regarding the use of new antibiotics which often combine 2 agents. There is some exciting new data emerging regarding the use of a sublingual vaccine, although currently this has only been evaluated in case studies with a significant risk of bias. Nevertheless, randomized controlled trials are planned to evaluate this further. Interesting results have emerged looking at bacterial adhesion inhibitors, and a naturally occurring sugar D-mannose has been evaluated in a 3-arm randomized controlled trial. This trial compared the use of prophylactic daily nitrofurantoin with D-mannose and placebo. The D-mannose performed equivalently to nitrofurantoin, which suggests it may be a reasonable non-antibiotic alternative in those with recurrent urinary tract infections. In conclusion, urinary tract infections can be recurrent, and they are a very common complaint. New antibiotics are few and far between, and I think we need to concern our efforts on non-antibiotic options going forward.